All right. So good morning. My name is Dr. Paul Mason. I'm a sports and exercise medicine physician, as most of you probably know. Today's tutorial is going to be a little bit different. We're going to base it around 18 multiple choice questions, and we're going to have an explanation at the end of each multiple choice question. So I'll give you a moment to have a look at them, but we won't run through them independently. And then we'll be followed by 5 case-based discussions. And what I'd like to do is to have somebody volunteer to be involved in each of the case-based discussions. And I think that'll be more useful that way. So let's kick on to the first question. So the question is, which of the following is true of dietary carbohydrate? It is an essential fuel to the brain. It's essential to replenish muscle glycogen after exercise. It's essential as an energy source for the retina. Or D, dietary carbohydrates are not essential. And the correct answer is D. As we'll see later, glycogen stores can be maintained on low-carb diets. And while glucose is needed for the retina, this can actually be synthesized by the process of gluconeogenesis. And dietary carbohydrates are not needed for this. So you need to understand that carbohydrates are basically polymers of glucose molecules. And after digestion, these glucose molecules will find their way into your circulation. And this is why dietary carbohydrate is so problematic for diabetes. Now, the fact that dietary carbohydrate is not essential to fuel the brain, we need to go back to where that claim was first made. And that was first made in this 2002 Institute of Medicine report. And that was based on research that showed that the brain, on average, can metabolize about 100 grams of glucose daily. And then they added another 30 grams as a fudge factor. The problem is the ability to use glucose is not the same as the need to use glucose. It's quite possible to fuel the brain on ketones. So this was proven by pioneering metabolic researcher George Cahill. He took 3 subjects who had been fasted for several weeks, meaning they'd already had low glucose levels, and then he infused them with 20 units of insulin over a 24-hour period. And as you can see, the glucose in their blood absolutely plummeted. It went down to less than 1.5 millimoles a litre, and one subject even went below 1. And these subjects all remained completely asymptomatic. The neurological function was retained. And the reason is obvious when you look at their ketone levels. The ketones simply replaced glucose as a source of energy. There's no obligate need for dietary carbohydrate for the brain. Of course, you obviously need a period of keto adaptation before you go injecting people with insulin and driving their glucose down to the ground. And that period of keto adaptation takes at least 2 weeks and preferably 4 or more. Okay, so question 2. Which of these diets has the strongest evidence for weight loss with ad libitum intake? So that just means when we're letting people consume as much food as they wish, but food only of a certain type. And I would hope that most of you would realize that the correct answer is B. So over the 20-year period between 2003 and 2023, the Public Health Collaboration in the UK identified 71 randomized controlled trials comparing low-carb and low-fat diets in terms of weight loss. And out of those 71 RCTs, 39 found statistically significant results. In other words, the findings were likely not due to random chance. And these are the results of the 39 randomized controlled trials. What you'll note is that in every single one of them, the low-carb arm did better in terms of weight loss. Could there be better evidence to demonstrate that low-carb diets are superior for weight loss than low-fat diets? And what's perhaps even more surprising is that to many of you, this will probably be news. Now, you might be interested in reading more about this topic. This is a list of more than a dozen meta-analyses on this topic. The point is the science is comprehensive, the science is in, and as doctors, we should be knowing this. All right, question 3. Which of the following statements is true regarding ketoacidosis and low-carb diets? A, low-carb diets directly cause diabetic ketoacidosis in healthy individuals. Low-carb diet induces ketoacidosis by producing excessive insulin in the body. C, nutritional ketosis from low-carb diets is the same as diabetic ketoacidosis. Ketoacidosis primarily occurs in states of insulin excess, or ketoacidosis primarily occurs in states of insulin deficiency. Now, the answer is E, and this is why we see ketoacidosis in type 1 diabetics who don't have much insulin. The high levels of insulin are protective against ketoacidosis. And you also need to understand there's a distinct difference between ketoacidosis and nutritional ketosis. And the conflation of the two is a reason why many people inappropriately avoid low carbohydrate diets. Now, ketoacidosis has a pH change, while nutritional ketosis, the pH remains normal. So this is a graph comparing the ketone levels versus pH in diabetic patients. And you can see that beta-hydroxybutyrate levels have to pass greater than about 5 millimoles a litre before somebody will enter even a mild acidosis. Oh, now I'm not sure what's going on here with, there we are. Understand that ketones greater than 5, even on very strict low-carb diets, are incredibly rare. So this is a starvation study, and it shows that even after 10 straight days of fasting, beta-hydroxybutyrate levels were below 10. So if you're in ketoacidosis, it's almost certainly caused by insulin deficiency and not simply because you're on a low carbohydrate diet. Question 4, which of the following foods has the highest glycemic index? Cornflakes, table sugar, honey, or banana? And the answer is A, cornflakes. You might be thinking, hang on, that doesn't have as much sugar in it. The cornflakes aren't as sweet as honey or table sugar. And the reason is the glycemic index is a measure of how rapidly glucose enters the blood. And cornflakes are predominantly, as a complex carbohydrate, made of glucose. Compare this then to other sugars, however, which contain fructose. So sucrose is a combination of one molecule of glucose, one molecule of fructose. Honey has a lot of fructose. Fruit, on average, is about 50-50 glucose to fructose. We know fructose by the other name of fruit sugar. And this fructose is not measured in the glycemic index. Now, unfortunately, fructose is actually proven to be more deleterious to our health than glucose. And this is the big failing of the glycemic index as a measure. You can have fructose-rich foods that simply don't get measured in the glycemic index. So you need to understand when we're looking at foods, when we're looking at different sugars and carbohydrates and so on and so forth, we need to consider the fructose content. Okay. Question 5, which of the following is true of keto-adapted, and this is long-term keto-adapted, over 9 months, endurance athletes? So baseline glycogen stores are deficient. Glycogen stores immediately post-exercise are deficient. Glycogen stores 2 hours post-exercise are deficient. Or there's no evidence of impaired glycogen storage as assessed by repeat muscle biopsy. You can probably tell this is quite a leading question, and this is actually based on a very, very good piece of research where they actually did muscle biopsies on athletes who were long-term keto-adapted. They compared habitual high-carb athletes to habitual low-carbohydrate athletes. BL stands for baseline. You can see even assessed by gold standard muscle biopsy, no different in glycogen stores. Immediately post-exercise, again, no difference. And post-exercise 2 hours, and this is after The high-carb athletes were given a high carbohydrate shake, and the high-fat athletes were given a high-fat shake. Again, there was no impairment of the recovery of glycogen. So we have clear evidence that repudiates the belief that glycogen stores need dietary carbohydrate to be maintained. That is simply not false. And when you understand this, you can begin to understand why this whole myth about glycogen being absolutely essential for anaerobic performance, for power performance, and that being the theoretical basis used to say that power athletes can't get by on low-carb diets. You can see that that's just a house of cards that begins to fall away. Now, this question was based on some very recent research. This was included in the recommended reading prior to this tutorial. Please select the most important mechanism by which carbohydrate ingestion can delay time to exhaustion with endurance exercise. Maintenance of glycogen stores, well, we've perhaps already seen that that's probably not a realistic, a probable cause. Reducing oxidative stress associated with fat metabolism, increased ketone body production, or reducing exercise-induced hypoglycemia. And the correct answer is D. Now, this is a very recent paper. One of the authors includes Professor Timothy Noakes, who obviously knows a thing or two about exercise physiology. And it was a blinded crossover randomized control trial. They had 10 male triathletes, and they were either on a diet of less than 50 grams of carbs or over 380 grams daily carbs. And what they found that 10 grams of carbs per hour in both groups prevented exercise-induced hypoglycemia and increased the time to exhaustion by 22%. Now, this is quite significant. So it demonstrates the mechanism by which dietary carbohydrates can be beneficial. And it also speaks to the notion of how much dietary carbohydrate do we actually need. There's a lot of, guidelines indicating we need to have certain amounts of carbohydrate in the glucose and fructose to support our physical performance. And I suspect that this relatively new piece of research is going to change that narrative. There was actually two other very important learning points to come out of this paper. So first of all, it took about 4 weeks for the blood glucose levels in the low carbohydrate athletes to stabilize, which is really suggesting that that is a minimum adaptation period if you're looking at commencing a low carb diet without having it deleteriously impact on your performance. The other interesting thing was that the ketone levels appeared to be unaffected by this low-dose carbohydrate supplementation, indicating that the previous fear that people have had that if you take carbohydrates then you impair the benefits of following a ketogenic diet, it appears that at least for this dose of carbohydrates, that is not the case. Okay, question 7. Which of the following statements about lipids is correct? Cholesterol may come in different isomers, commonly referred to as good and bad cholesterol. LDL is a pathological entity that has no known physiological role in the body. Epidemiological research indicates lower serum LDL levels are associated with increased all-cause mortality. Cholesterol is a type of lipoprotein involved in the transport of triglycerides, and E-lipoproteins are enzymes that hydrolyze free cholesterol in the circulation. Now, I guess when I wrote this question, I really wrote it with a view, with a memory that when I was a medical student and a junior doctor, I truly didn't understand cholesterol. When I saw cholesterol written on the pathology form and it said cholesterol, I assumed that that actually meant cholesterol, but it actually doesn't. So when they say cholesterol on the pathology results, it actually means lipoproteins, and cholesterol is actually a sterol molecule. It's a molecule that can no more have good and bad forms than water can have good and bad forms. So most of these options here are completely spurious and scientific nonsense distractors. So when we say it's a pathological lipid that has no known physiological role in the body, well, the body devotes an enormous amount of resources to making something that would be highly unusual if it had no known role. And indeed, it has multiple roles, not least including as part of the immune response. as we'll see, that C is actually correct. And this is going to surprise a lot of people because we call LDL bad cholesterol. We think higher levels must be associated with increased mortality, when in actual fact the reverse has been robustly shown to be true, as we'll see in a moment. Point D, when I said cholesterol is a type of lipoprotein involved in the transport of triglycerides, well, no, cholesterol is a sterol molecule. And people conflate cholesterol with lipoproteins, but they really should not be conflated. Scientifically, that's completely inaccurate. And E, again, was just another complete distractor. So we'll have a look at this British Medical Journal article. It was a systematic review, and it looked at 19 prospective cohort studies that had over 68,000 participants. And the overwhelming finding was that individuals with the highest LDL levels tended to live longer. That was a finding of 16 of the 19 studies that found that relationship. Basically, the higher your LDL level, the lower your chance of dying. And when we actually have a look at each of the individual studies within there, it doesn't matter how we slice it or dice it. When you can see the quartiles there in the center, comparing the very highest LDL group with the lowest, or even just the second lowest, the high LDL levels prove to be superior. And then we have people making arguments about reverse causality, that it's, just when people become very sick that their cholesterol lowers, and that's why we see this association. This study, for example, excluded subjects with terminal disease, with heart disease, with diabetes. They got rid of those chronic diseases, and the results still stayed the same. This study found that there was a 50% reduction in the chance of death in the highest LDL group compared to the lowest. In a nutshell, the findings of this systematic review are robust, and it's simply scientifically dishonest or disingenuous to dismiss or ignore it. So then, still on cholesterol, which of these factors increases the production of low-density lipoprotein? A high dietary saturated fat intake, low carbohydrate intake, low serum B12, or a low serum vitamin C. So just pause for a moment and think about what you think to be the correct answer. Now, most people, traditionally trained doctors, would pick A. And you would be surprised to know that there's no proven mechanism by which saturated fat can actually increase LDL. So this study looked at the impact of 3 fats: olive oil, which contains 19% saturated fat, butter containing 66% saturated fat, and coconut oil, which contained 94% saturated fat. And they looked at the impact of those fats on cholesterol levels. Now, the traditional dogma would have you believe that the coconut oil group must have seen significant rises in LDL levels. In actual fact, the LDL level in the coconut supplementation group actually fell, and it actually reduced by more than the olive oil group. And the fact is, there's no proven mechanisms by which saturated fat can increase LDL levels. It's never been shown, and yet somehow this has ended up as an indisputable accepted fact in medicine, and it really needs to be overturned. On the other hand, vitamin B12 deficiency has been proven to increase cholesterol synthesis. And not only that, we even understand the underlying molecular mechanisms. All right, now this is an interesting one. So this again goes against a long-held dietary wisdom and dietary dogmas. Large-scale randomized controlled trials evaluating the replacement of dietary saturated fat with seed oil-derived polyunsaturated fats. That's a mouthful. Basically, they took out saturated fat and they gave people seed oils. They've found A, increases in all-cause mortality, B, reductions in all-cause mortality, no significant change in all-cause mortality, or D, these studies have never been performed. Now, some of you might pick D, and that's not unreasonable, but that's incorrect. These studies actually have been performed. The unfortunate thing is that many of us doctors have simply not heard about these studies, or we haven't looked at the results of these studies. The answer is actually A. Removing saturated fat from the diet and replacing it with seed oils actually increases all-cause mortality. So the first large-scale RCT to examine this question was from 1965. Heart attack survivors were randomly allocated to receive either a supplement of corn oil or the regular diet. And after 2 years, 48% of those in the corn oil group had had heart attacks compared to only 25% on regular high saturated fat diets. The next study is much closer to home for us, Sydney Diet Heart Study. This was a randomized controlled trial examining the effects of replacing saturated fat with polyunsaturated fat in men who had heart attacks. And it found that those Australian males who increased their intake of these seed oil-derived fats were 62% more likely to die. And finishing in the same year, we've also got the Minnesota coronary experiment. This was a double-blinded, randomized controlled trial on more than 9,000 men and women. And again, subjects who replaced saturated fat with polyunsaturated fats faced an increased risk of death. And indeed, this was shown again in the Women's Health Initiative study. Now, published in 2006, this was a massive study of over 48,000 females, and it had a mean follow-up of 8.1 years. And not incidentally, it was horribly expensive, costing about $700 million US, which means we don't get a do-over. And this modern-day randomized controlled trial found a 26% increased risk of cardiac complications in those females randomized to a reduced saturated fat diet. Now, I wouldn't be surprised if all of this was news to you. Now, the reason is that the original investigators weren't completely transparent about these findings. So the Sydney Diet Heart Study, for example, it was completed in 1973, but the mortality data wasn't published until some 40 years later, after the data was actually discovered in a basement. The Minnesota Coronary Survey also finished in 1973, and it took 16 years for a redacted version of the findings to be published. And again, it wasn't until 2016 that a more complete version was finally published, again after a chance finding of the study data showed up in a basement. And you can't make this up. And as for the Women's Health Initiative study, the only statistically significant finding of a whole study just happened to be left out of the results table, and it was never mentioned in any press conference. This vague sentence on page 661 of the publication was the single reference to it, the finding being that females with a history of heart disease faced a 26% increased chance of complications like heart attacks when they reduced their saturated fat. And follow-up to the Women's Health Initiative study demonstrates that this risk only increased with time, this paper reporting a 61% increased risk of cardiac complications in the reduced saturated fat group. Now, nobody really knows why these 4 randomized controlled trial studies, the findings haven't been effectively disseminated. So Ivan D. France was a co-principal investigator on the Minnesota coronary experiment, and he indicated that may have been due to the difficulty he had in reconciling the study's findings with his belief that saturated fat to be bad. So when he was asked directly about the delay in publishing the findings, he stated, "We were just disappointed in the way it came out." So I guess if you take one thing away from this tutorial, please make sure you look at the data yourself, that you don't just accept common belief, because all too often we find that the common belief is incorrect. All right. Question 10. Which of the following best describes the primary source of elevated serum palmitic acid levels in the context of metabolic disease? Now, what do I mean by this? So palmitic acid, or palmitate, this is the saturated fat that everybody worries about. We worry about consuming it. And we know from observational data, epidemiological research, that people with increased levels of palmitic acid in their blood have an increased rates of mortality. They have increased rates of metabolic disease, diabetes, so on and so forth. So the question is, where does this saturated fat, where does this palmitic acid come from? So option A, it comes from foods like red meat and dairy products, which are rich in palmitic acid. Does that make the palmitic acid levels in the blood go up? It comes from increased de novo lipogenesis in the liver, which turns carbohydrates into palmitic acid. Or C, impaired beta oxidation of palmitic acid in mitochondria, or D, enhanced absorption of palmitic acid from plant-based oils? Now, the answer is B. The body actually can convert carbohydrate into palmitic acid, and this has been proven to be a more significant factor in rising palmitic acid levels than the direct consumption of palmitic acid itself. This is an incredibly important point. This study fed subjects on either low-fat, high-carb diets or high-fat diets. And after 10 days, there was a significant increase in palmitate levels in the low-fat fed subjects. In effect, they found higher levels of this saturated fat in the people who were consuming low levels of that saturated fat. And here's why. Excess dietary carbohydrates can be directly converted into fatty acids via the process called de novo lipogenesis. This graph is from an overfeeding study where subjects consumed carbohydrates in excess of their actual needs. So you can see, despite consuming excess carbohydrates, the rate of glucose metabolism was relatively constant. And incidentally, this busts the myth that you can stimulate your metabolism simply by eating regularly. Initially, in the first few days, a lot of the excess carbohydrates was soaked up in the form of glycogen. It could be actually stored in muscle and a little bit in the liver. But as the glycogen stores became saturated, the excess glucose got turned into fat. De novo lipogenesis, literally making fat from sugar. Now, you probably know this fat by another name as triglycerides. And experimental research shows that feeding carbohydrate increases saturated fats much more than consuming saturated fat itself. Very important point to understand. All right, question 11. Which of these plant proteins provides all 9 essential amino acids in quantities sufficient to meet human needs? Lentils, wheat, peanuts, and soy. The answer is soy. And this is one of the few plant proteins that provides all of the essential amino acids in near adequate amounts. Lentils are low in methionine, wheat is low in lysine, and peanuts are deficient in both. So soy protein is widely considered to be the most complete source of plant-based protein, although methionine is still a limiting amino acid. This study, for example, found that skim milk resulted in a 43% higher muscle protein synthesis rate than soy milk. So the fact is, most plant proteins are incomplete. And you also need to be familiar with something called protein complementation, which is if you have vegan or vegetarian patients, they need to combine plant proteins from different sources to achieve a more complete amino acid profile. Question 12. Which of these cannot be found in red meat? Taurine, genistein, creatine, and vitamin C. And the answer is B, genistein. This is an isoflavone that is found in soy protein, and it actually binds to estrogen receptors, and therefore it's got estrogenic activity, especially in states of low background estrogen, such as in a male or in a menopausal state. Now, this question, I really wrote this to make the point that red meat is nutritionally dense. There's a list of about a dozen nutrients that are either absent or deficient in plant foods, which are contained in red meat. So please don't just consider red meat to be a protein, which we often consider it. Please do consider it as a source of micronutrients as well. Now, you might be pondering the vitamin C option. Because everybody knows that red meat is deficient in vitamin C. And if you're looking at the USDA nutrient data for beef, you would see that indeed meat doesn't have any vitamin C. The thing is, this data was formulated without actually measuring vitamin C levels. They assumed it was 0 and simply accepted it and repeated it without question. When it's actually tested, though, we find that red meat does contain vitamin C, which is no doubt what we would have predicted if we were students of history. So Arctic explorers for a long time have used fresh meat to treat scurvy. as did Napoleon's army during the 1801 siege of Alexandria, where they consumed horses who had perished in battle. Okay, question 13. Which of the below statements concerning anti-nutrients is incorrect? Now, many of you probably have never even heard of the term anti-nutrient. It sounds pseudoscientific, but it is absolutely an accepted concept. A, anti-nutrients contained within corn have been shown to completely inhibit absorption of zinc. Concurrent consumption of vitamin C can eliminate the impact of anti-nutrients. C, anti-nutrients such as phytates, tannins, and oxalates can reduce the bioavailability of minerals like iron, zinc, and calcium by binding to them in the gut. The low absorption of iron from legumes, approximately 1 to 2%, is primarily due to anti-nutrients. Anti-nutrients may impact the absorption of protein by forming insoluble complexes and inhibiting proteolytic enzymes. Now, the correct answer, I think I may have miswritten this question. So anti-nutrients within corn completely inhibit absorption of zinc. That is absolutely correct. Concurrent consumption of vitamin C can eliminate the impact of anti-nutrients. Well, no. So the correct answer here, or the incorrect answer, is actually B. So talking about why, let's have a look. This study fed subjects oysters and measured their zinc absorption. And you can see they managed to absorb a good amount of zinc, as you can see by the area under the curve. But when we fed them the same meal of oysters with black beans, we significantly attenuated the absorption of zinc. You can see it's probably down by 2/3. But look what happened when they were given corn. The absorption of zinc reduced to all but 0. This is the effect of anti-nutrients. These are compounds typically in plant foods that bind nutrients and prevent their limit their bioavailability for human digestion. As for iron, in the question we referred to iron having a bioavailability of 1 to 2%. This paper found that iron in 5 commonly consumed legumes, which it must be said are commonly recommended as a source of iron for vegetarians, was only 1 to 2%. So please have some awareness of these compounds within plant-based foods, phytates and tannins and oxalates and so on and so forth. These change the amount of nutrients that we can actually digest and absorb from food. So just because it says X milligrams of iron on the label doesn't mean that you're getting X milligrams of iron. Question 14. Which of the following is incorrect? Dehydration up to 3 to 4% in well-trained cyclists does not impair physical performance. Observational field data have reported dehydration levels of 6.6 to 11.7% body mass in male marathon winners. Observational research identifies most successful marathon runners drink fluids to first. Maintaining body weight is an effective means of avoiding dehydration and improving exercise performance. Muscle glycogen depletion results in the release of bound water, a 3-to-1 ratio. That ratio that is listed there is incorrect, actually. That's meant to be 1 to 3. The electrolytes contained in sports medicine drinks are generally considered sufficient to prevent exercise-associated hyponatremia. And the correct answer here that I was actually looking for was D. Let's have a look at some really interesting studies on this. And the reason I've done this, I've been in many club rooms, elite level sports, where I've seen dietitians come up and put players on scales to make sure they haven't lost any body weight over the course of the game. Otherwise, they're dehydrated, and that's considered problematic and going to affect their performance. And they're told to strictly hydrate. And we tell athletes to hydrate so their urine remains a light straw color, because anything that's approaching yellow is a proof of dehydration. And these are simply incorrect and bad practices. So, first of all, this meta-analysis concluded that up to 4% body weight dehydration didn't alter cycling performance. And this study was quite interesting. So they looked at 13 international marathons and they looked at the weight loss in the winners. And the minimum body weight that they actually lost was 6.6%, which tends to suggest if you're not losing at least 5% of your body weight, you're probably not going to win a marathon, which is quite interesting. Now, understand that glycogen in the muscles, you are going to have some glycogen depletion, but as you deplete that glycogen, you're also going to lose some water. You're going to release water. So that is going to be an insensible loss that you can't control, but it's not the same as dehydration. So you're going to have a degree of body weight loss through that as well. And so essentially, if it's been shown that if you're not losing weight, you are at risk of exercise-associated hyponatremia as well. So there are consequences to doing this. Also, one of the points is that the job of the kidneys is to concentrate the urine. So we know that one of the first signs of kidney failure is loss of concentrating capacity. The kidneys want to concentrate. They want to give you yellow urine. They want to give you a highly osmolar urine. So we should let the kidneys just do their job and not try and interfere. If you've got healthy kidneys and you're drinking enough that your urine is light straw-coloured, as is often recommended or encouraged, you're basically overcoming your natural kidney function. So just be mindful that overhydration probably causes more problems or can cause significant problems, and drinking to thirst is a very good notion during athletic events. You reduce the risk of exercise-associated hyponatremia, and it also appears to be very consistent with good sporting performance. All right. What is the approximate mean peak fat oxidation rate of high carbohydrate endurance athletes? So these are athletes on a traditional diet that we traditionally recommend, lots of sports gels, lots of Gatorade, lots of pasta, carb loading, so on and so forth. Now, the answer is B. It's usually considered to be about 0.5, maybe 0.6, 0.7 grams of fat per minute. So if we have a look at this study here, this was the study we saw earlier with the glycogen biopsies, and the high carb athletes in this study, they were shown to have a mean peak oxidation of 0.67 grams per minute. But when we compare it to the low carb athletes, they had a mean peak fat oxidation of over 1.4 grams a minute. So a significant difference in their ability to use fat as an energy substrate. Now, if we actually graph this against VO2 max, here you can see, so elite marathoners, they'll race at about 80% VO2 max, and you can see at about 82% VO2 max, the low-carb athletes are still burning a lot of their energy from fat. And it's constantly being said, oh, you can't do any kind of exercise with any kind of, once you get up in the VO2 max, you just can't burn fat. Well, this has simply been shown to be false. You actually can a fairly significant rate. And if we actually, consider how this affects your glycogen stores, we can see that you'll actually, preserve a lot of your muscle glycogen stores simply because you're burning more fat. And there's other benefits to burning fat as well, which we don't have time to go into. Question 16, which of the following is true? Weight change is independent of the macronutrient source of energy. So that means, it doesn't really matter if you're having, fat or carbs or protein, it's the calories, the total number of calories that will affect your weight loss. B, differing hormonal responses to macronutrients influence weight change. C, processing of food to alter solubility does not influence weight gain. And D, insulin increases energy availability. And the answer is B. And it's to do with insulin. D was actually a distractor. Insulin actually reduces energy availability. And this is going to be a very important concept later when we go through the case-based discussions. And the reason that it's important to understand insulin can impact energy availability is because carbohydrates stimulate the release of insulin. So first of all, let's have a look at the evidence that insulin may actually contribute to weight gain. This 2007 cohort study followed youth for 8 years, and they stratified them by the insulin level. And only 2% of those with the lowest levels of insulin in the bottom 25% became obese over the 8-year period. Now, those with the highest levels of insulin, they had 36 times greater risk of developing obesity. They had a 72% risk of becoming obese. So we've got good evidence that insulin is actually fattening. And we also know that when you consume an isocaloric amount of carbohydrates, it leads to a significant increased rate of insulin release compared to fat. And it's this carbohydrate-induced insulin release that is a major factor for weight loss, as we showed you earlier with all the randomized controlled trials comparing low-fat diets to low-carbohydrate diets. This is why low-carbohydrate diets are so superior in terms of weight loss. Now, Professor Kara Ebeling and Dr. David Ludwig, they were principal investigators on this study, and it compared low-fat and low-carb diets, and it looked at something called energy expenditure. So after losing weight on an energy-restricted diet, the subjects were randomly allocated to diets either low-carb or low-fat, and the protein was held constant. Now, there was an interesting wrinkle in this research. So the researchers wanted to keep the weights of the subjects stable, but the problem was the low-carb diet group kept on losing weight, and the researchers actually had trouble maintaining the weight on the low-carb diet. So they actually had to significantly increase the caloric intake in the low-carb group to prevent weight loss. They didn't have that problem in the high-carb group. Now, at the end of the day, this was a 5-month rigorously controlled randomized controlled trial, and it found that the total energy expenditure of subjects on a low-carb diet was 300 kilocalories a day greater than those on the high-carb, low-fat diet. They essentially got a free lunch equivalent to an hour's bike riding every day, and they were calorically controlled. The only difference was the change in macronutrient composition on the diet. Okay, which of the following is incorrect? Inadequate phosphate impairs ability to form bone or muscle. Sodium depletion adversely impacts bone health. Inadequate nitrogen, phosphate, and potassium can impair muscle synthesis. Enlargement of fat stores requires both glucose and protein. And the incorrect option is D. Fat store does not require protein. It only requires glucose. So body tissues are made up of specific nutrients, and each of these nutrients must be present in the correct proportion for proper tissue formation. If any nutrient is deficient or imbalanced, the development of that tissue will be impaired. And not only can this hinder healing, but surplus nutrients not used for tissue repair can be converted into energy and stored as fat. And that's why ensuring complete nutrition is important, and this was shown elegantly in this 1975 study. So 11 underweight subjects were fed a complete formula exclusively through a vein, parenteral nutrition. And they were underweight, and they were basically overfed with this nutrition. They were provided with excess calories. So predictably, these subjects would gain weight. Now, the researchers also meticulously collected the urine and feces of the subjects, and they measured the excretion of nitrogen, phosphate, potassium, sodium, chloride, and calcium. And because they knew the ratios of each of these nutrients within bone, muscle, and fat, they could determine how much of each tissue was being formed in each subject. Now comes the twist. The researchers then selectively removed each of these elements from the infusate. And they found that removing nitrogen, phosphate, or potassium completely halted the formation of muscle. If they didn't have sufficient nitrogen, which is a proxy for protein, phosphate, or potassium, you cannot make muscle. When they removed phosphate and sodium, they prevented bone formation. And when they removed nitrogen, they reduced the bone formation by about 75%. And when they removed potassium, by about 65%. So phosphate and sodium were clearly the most important for bone, but all 4 of these were incredibly important. And we've shown this by research. The Women's Health Initiative showed that, low sodium diets increase the rate of osteoporosis. Then what about fat? Now, in the words of the researchers, an abundant supply of glucose was the only requirement for the enlargement of adipose tissues. So when bone and muscle can't be formed, the inputs that would otherwise go to lean tissue are instead directed into fat stores. And there's clinical randomized controlled trials to support these findings. This was a double-blind randomized controlled trial published in 2015, and they supplemented subjects with phosphorus and they examined their weight gain and waist circumference. And the subjects who were randomly assigned to receive the phosphate lost weight in a significant amount, and they also had improvements in their waist circumference, glucose levels, and insulin levels. The only intervention here was giving them extra phosphate, and they lost weight. Now, just in this context here, I'd just like to briefly discuss the Supernova study, which most of you will probably be familiar with, which apparently concluded that ketogenic diets are bad for the bone. We'll understand that we know that, micronutrients like potassium are very important for the bone. And if you realize that the subjects, the ketogenic athletes in this subject, were actually deficient in potassium, their potassium intake was actually below the recommended daily intake levels. So this is a significant confounder. So it's simply implausible to attribute the ketogenic diet effects on bone when we know the potassium deficient state. So I'd just like to make that point. Question 18, we're getting close to the end here. Which of the following is incorrect? Bone mineral density has been shown to increase secondary to nutritional intervention in postmenopausal females. That's a big claim. Protein comprises 10% of the dry weight of bone. Non-pharmacological restoration of bone mineral density is not possible in postmenopausal females. Pharmacological inhibition of osteoclast activity results in an improvement of bone microstructure. And the correct answer is B, or the incorrect answer rather, is B. So protein scaffolding comprises about 30 to 40% of the dry weight of bone. And this is incredibly important because you need to understand, if we look at bone is basically mineralized protein. So we have hydroxyapatite that's packed in with other trace minerals in between the protein fibrils, but we need the protein. So if we're just supplementing solely with calcium and trying to build bone, then you can see the limitation of that. Then we need to, if we want to build bone, we need to provide all the micronutrients which are involved in bone. And that's what the previous TPN infusate study demonstrated quite elegantly. Now, this was a randomized double-blind placebo-controlled trial. They took men and women over the age of 65. So this includes females who are menopausal, and they randomized them to either vitamin D and calcium or a placebo, and their bone mineral density was monitored. So vitamin D and calcium. And what they actually found that overall supplementing with vitamin D and calcium reduced their losses of bone. Now, this is logical because bone gets broken down to release calcium if we need calcium. So if you've got more calcium coming in, you reduce the body's need to break down bone. So it makes sense that supplementing would reduce the decline in bone mineral density. But it doesn't give the ingredients you need to build more bone. But then the investigators did something particularly clever. They stratified the results based on protein intake. And what they actually found was that the tertile consuming the most protein while also receiving vitamin D and calcium increased their bone mineral density in an elderly population, which included postmenopausal females. So if you provide all the substrate that you need to make bone, even postmenopausal females can reverse osteoporosis. Now, I'd just like to mention very briefly the pharmacological treatments for osteoporosis. And I have seen some of these agents used to manage fractures in athletes, and this is completely and utterly, for the most part, depending on the agent, inappropriate. So we have drugs like bisphosphonates, which actually inhibit osteoclast activity. You need to understand what is happening. We're getting an increase in bone mineral density because we're reducing the body's ability to break down bone. That's fine. But part of that breakdown of bone is actually normal and healthy. We know about bone coupling. We've removed the defective microtuberculae that happen through stress fractures or what have you and replaced them with new ones. Now, the drug classes like bisphosphonates, they stop you breaking down bone, so your bone mineral density goes up. Fabulous. But then we do see this increased risk of atypical fractures. The bone becomes more brittle. The quality of the bone is actually impaired. So any pharmacological intervention that reduces the removal, that inhibits osteoclasts, almost certainly impairs the quality of bone. So increased bone mineral density is not the same as better bone. Now, there is one exception to this. We have pulsed parathyroid hormone, which we know if we give parathyroid hormone on a pulse basis, it can actually stimulate osteoblastic activity. And I think in certain circumstances, and this is certainly not going to be a discussion on that, but pulse parathyroid hormone can be in appropriate populations an effective treatment. Just be mindful of the way that it works to build the bone. It actually has to suck all of those micronutrients out of the blood to push them into the bone. And while it's doing that, it can actually adversely affect the levels of those micronutrients in the blood, and that can actually lead to symptoms. So you need to make sure that you've got adequate intakes, adequate supplementations going on if you are going down that track. And obviously there's a theoretical risk of cancer in pediatric subjects, so on and so forth, but we're not talking about that now. Who do we have?
Emma, I'm from Victoria.
Emma. Greetings, Emma. What year are you?
Second.
Excellent. Well, you're braver than everybody else.
Yeah, someone to me.
So what we've got here, we've got a 52-year-old male who's a bit overweight, and he's got a fasting blood glucose of 6.9, which is probably below the diagnostic threshold for diabetes. He has a standard Australian diet, which should tell you a lot, and is a bit plump around the middle, and he's got mild hypertension. So I guess, I might open the floor to you about how you would, what your thoughts are on this stem and how you would initially like to approach it.
Well, I guess my initial approach would be probably taking a bit more of a history. It sounds like examination's been sort of somewhat done. But I guess in terms of history, trying to work out a little bit more about whether he has any medical conditions that have caused him to be this way, whether he, to be overweight, whether he's got any other medications, whether his hypertension's been treated, or whether he's seen a dietitian previously to try and manage that with diet, whether he's had sort of regular blood tests which point to other cardiovascular risk factors. And then probably just exploring a little bit more about his diet and his exercise habits, his sedentary behaviours, his job, whether he's always been overweight or whether this is something that's sort of come on with age or a particular change in lifestyle. But where to start?
So probably like most males, he's probably quite inattentive to his health, and you can probably assume that this is a primary presentation. But he does have a few old blood tests. What blood test in particular would you like to look at for cardiovascular risk?
Well, probably fasting lipid studies, an HbA1c as well. And then, are you asking if I just had one, or if I can I have a lot?
You can have as many as you like. It would be nice if you would limit it to the ones that you would personally find most useful and feel the most comfortable chatting about.
Fair enough. I'd probably also want LFTs, seeing whether he has any sort of fatty liver type picture, kidney function and FBA as well. I think if he had hypertension, he's of an age and a sort of a risk profile where it's probably secondary hypertension, but potentially if it was new and hadn't been investigated, like at least a kidney function, if not primary hypertension, but otherwise a screen for that. And those would be the main ones I would start with as sort of a primary look. And obviously if there was like risk factors that came up in the history, you could think about things like thyroid or hormone function, depending on what we thought was the cause.
Okay, well, you've got some excellent things there. So I guess with fasting lipids, so I probably won't put you on the spot with that one, but I will make the point that When it comes to assessing cardiovascular risk with a lipid panel, there's a metric called the triglyceride to HDL ratio, which is far superior to other metrics. When we're looking at absolute level of cholesterol or absolute level of LDL, the triglyceride to HDL ratio is a far superior metric in the assessment of what we call atherogenic dyslipidemia, which is basically saying, is somebody likely to have a heart attack based on this lipid profile? So again, you saw what I talked about earlier with LDL and so on and so forth and all-cause mortality. Now, one thing to understand, though, is that I also gave you a question that demonstrated that low vitamin B12 levels can actually increase the rate of lipid synthesis, LDL, so on and so forth. So if you do see somebody with a good triglyceride to HDL ratio, that doesn't let them off the hook entirely if their cholesterol level is, quite high, getting in the 7s and 8s and so on and so forth. And it's worth having a look at these underlying factors, which we know can actually increase cholesterol levels. So we know, for example, an underactive thyroid, you mentioned that, an underactive thyroid is associated with increased cholesterol levels, deficiencies of what we call the methyl donor nutrients, B12, folate, betaine, choline, so on and so forth, that is associated with increased levels of cholesterol. In terms of things, we know that hemochromatosis, iron overload, is associated with hypertriglyceridemia, and even a hemochromatosis carrier state, you don't have to be homozygous, you can be heterozygous and still have borderline triglycerides. So there's a lot to dig on, but this is not a lipid shoot, so we won't do too much on that. But HbA1c is a lovely thing to do, and that's really not done often enough. But just be mindful that HbA1c has some limitations. So when we're looking at HbA1c, what is it? We've got a red blood cell and it's got sugar attached to it, non-enzymatically attached to the red blood cell. So what two factors influence HbA1c levels? So are you able to give me one factor now that would increase somebody's HbA1c?
Your concentration of red blood cells, like anemia, can change it, and then also your blood sugar levels, like your chronic.
Blood sugar is the obvious one, and you are absolutely correct about anemia. But that's more because of the lifespan of the red blood cell. So if you've got more sugar in the blood, more of it's going to attach non-enzymatically to the red blood cell. But what happens if your red blood cells are living for a lot longer? If because of a deficiency they're just not turning over, then you'll get an exaggerated HbA1c reading. What happens if you've got a lysis syndrome, hemolysis, and you've got a very short red blood cell lifespan, which, by the way, you can get a feel for with something called reticulocytes, the new red blood cells.
Yeah. So that would lower then in that case. Like you get a falsely reassuring HbA1c if you've got fasting.
Exactly. So my preference is to actually throw a continuous glucose monitor on people. And with a doctor's letter, people can get you don't need to be diagnosed as type 2 diabetic. You can get one with a doctor's letter. And Freestyle or Abbott have a deal on at the moment where the first one is only $15. And I think that's an absolutely beautiful thing for most people to do. Now, you mentioned LFTs, which is absolutely 100% correct. I just want to talk briefly about the biochemistry of the LFTs. These are commonly misinterpreted. So there's two that we mainly look at. We'll just put GGT and ALP to one side, alkaline phosphatase to one side. We'll just look at AST and ALT. Now, AST is usually found in not insignificant amounts in skeletal muscle. So if you've ever got a rise in AST, that's very suggestive that there could be a muscle problem. And you'll also have a look at creatine kinase, which is another intramuscular enzyme. And you'll usually see that AST and CK levels will usually track together. ALT is much more preferential to liver itself. But understand there's two possible causes for ALT being raised. You can actually have hepatocellular damage and you'll get that enzymatic leak, which is, very predictable. But it's also an enzyme that's associated in energy. The dealing of pyruvate. And if you have an energy excess from a high carbohydrate diet, that can actually induce ALT levels to increase. So I won't bore you with the biochemical mechanisms, that just understand high ALT may be a sign of early metabolic derangement. And that's why we often see it elevated in pre-diabetes or diabetic states. It's not just hepatocellular damage in the way that GGT is an inducible enzyme. ALT is also an inducible enzyme. You also talked about hypertension. Does this gentleman have hypertension?
It sounds like a trick question. I mean, he does in the room. I mean,
Well, it does technically. No, absolutely, he does. But I guess the question is it hypertension we should be concerned about? Does the categorization of him as hypertension, does that marry up with the science about what we should be treating? Now, I would argue that if we look at the literature on all-cause mortality, there's very little difference in all-cause mortality in a systolic blood pressure of 140 to that of 120. And especially when we look at the longer-lived populations, if we want to establish longevity, we want to look at who are living the longest. Well, you know, the oldest people, there's no real difference in mortality with a systolic of 120 to 140. The other fact is that we're often focused heavily on pulse pressure or diastolic pressure. And to the best of my ability, when I've actually looked at the literature, the predictive value of diastolic pressure and pulse pressure is far inferior to that of systolic pressure. So for the most part, I tend to just focus on systolic blood pressure. And in terms of all-cause mortality, if I'm saying, yes, trick question, I said mild hypertension here, but certainly that's not something that I would be concerned about. I'd say, okay, 140, let's watch that one. I'm certainly not going to scare the patient and saying, we're going to put you on blood pressure medications, you're going to die, so on and so forth. And we often gaslight our patients. We see patients get scared by these kind of numbers. Statistically speaking, 140 systolic is simply not that bad. But I think the glucose of 6.9 is what mostly concerns me. Do you have any thoughts on that?
I think maybe more from this talk, but prior to today, I probably would have said no. I think it's still under the diagnostic criteria for sort of pre-diabetes or diabetes.
Yeah.
But I mean, presumably it is still higher than we'd want in the context of someone with metabolic syndrome.
Absolutely. And we know this is pre-diabetes. I mean, we can call it pre-diabetes. We even have another condition called pre-diabetes, which we can talk about the mechanism of. But basically, it's a scale, it's a continuum. We often think about these things as dichotomous variables. It's either good or it's bad. I mean, these reference intervals really lend themselves to that. You're in or you're out. But if we actually look at the data, they're on a continuum. And this guy is certainly headed for bad health. And of his cardiovascular risk factors, the elevated glucose really stands out to me. And I would actually argue that somebody with pre-diabetes probably should be given exactly the same lifestyle interventions as somebody with diabetes. Now, here's an interesting question, and you may not know the answer, and if there's anybody else who wants to chip in, it's what is the underlying pathophysiological cause or the likely pathophysiological cause of his glucose being slightly elevated at 6.9?
I would have thought it would be more of a type 2 diabetes pathway, so sort of burning out of the insulin-producing cells in the pancreas, but be my thought.
Right, so
introducing insulin insensitivity.
Exactly, insulin resistance. So the insulin this gentleman has is in all likelihood not working properly. But that's not the full story, because we know that in about 10 to 15% of adults diagnosed with type 2 diabetes, they actually have an autoimmune form. We can call it latent autoimmune diabetes of adulthood. And you have a combination of insulin not working properly, that's the insulin resistance, combined with an insulin deficiency problem. And that's what you just referred to when you said the pancreas, the beta islet cells in the pancreas burning out. So this is almost certainly an insulin resistant problem. But we do need to try and get a feel for, well, is it possible that he could be one of these 10 or 15% who's, failing to produce enough insulin, because they need to be managed differently. If your insulin's not working properly, lifestyle management, such as an appropriate reduced low carbohydrate diet, exercise, so on and so forth, can be absolutely fabulous. But if you're deficient in insulin, and you've tried everything lifestyle and you've maxed that out and your sugar's still high, then you need to replace that insulin. There's no other two ways about it. And the best way to do this is with a modified oral glucose tolerance test. So we give people, they have the 75 grams of glucose and we measure their sugar level. And at the same time, we measure their insulin level. Because if we see that somebody in a type 2 diabetic, we'll see the insulin level will be really high. Their pancreas is releasing the insulin, but it's just not doing its job. But if you're going into this LADA, latent autoimmune diabetes of adulthood, you'll start to see the pancreas starting to fail. The insulin is actually inappropriately low. So it's very important to try and get a feel for those two different cases there. So one of them, insulin's not working. The other one is you just don't have enough insulin. And this oral glucose tolerance test with insulin, it can be done, you can order it if you want, is the most effective way of assessing for a deficient insulin secretion. Now, just as an aside, we mentioned blood pressure earlier, and you sort of mentioned, or you alluded to essential hypertension, which is just blood pressure that occurs. In actual fact, it's the action of insulin, usually in a hyperinsulinemic state on the kidneys, that drives essential hypertension. And nephrology doctors understand this very well. So you're probably familiar with the epithelial sodium channel, the ENaC channel in the kidneys that actually retain sodium. So this is what aldosterone acts on. Well, insulin activates the same transporter. So we know that basically if you've got excess insulin acting on the kidneys, that leads to excess sodium retention. It's the sodium retention that drives the blood pressure. So if you've got somebody, so if he's a bit mild hypertension, let's not start this chap on drugs. Let's have a look at his insulin and try and deal with his insulin resistance. And the fact that he's on a standard Australian diet really tells us he's probably on a crappy diet. His, the standard Australian diet is a very, very low bar. Now, I'm not sure that we've got a lot else. You also mentioned thyroid testing. I'm not sure that, obviously thyroid can affect your lipids. Interestingly, it's often overlooked, is with an underactive thyroid, that will actually lower your blood pressure. So this is particularly common in females. We might be having them come in and their blood pressure might be 110 systolic or even 100 systolic. And we often write it off because we've been led to believe that low blood pressure is always better. And that's simply not the case. And it's often that you have subclinical hypothyroidism or even, florid hypothyroidism. And often I'll only pick that up when I take their blood pressure and say, well, your blood pressure is quite low. And we do further investigation and we'll discover that. One other point that I think we should talk about, we talked about ketoacidosis and understanding the difference between ketoacidosis and nutritional ketosis. And we said that insulin is the key. Now, because 10 or 15% of people with type 2 diabetes may actually have low insulin levels, they might be at increased risk of ketoacidosis. And you've probably heard there's this class of diabetic drug called the SGLT2 drugs, which are associated with ketoacidosis. In actual fact, the literature is very clear that when we look at those case studies, we only really ever see that they cause ketoacidosis in people with insulin deficiency. So if you're going to medicate for diabetes, or if somebody's on one of these drugs, the SGLT2 inhibitors, then you really should be at least doing a fasting insulin to make sure they're not insulin deficient. What about
Sorry,
yes.
can I ask a question just about the lipid studies? I know this isn't a lipid shoot, but you were talking about Emma was talking about sending off fasting lipids, and you were talking about HDL, LDL ratio. What's your 2 cents on apolipoprotein B, and would you routinely send it off for patients like this?
This is a little complex. So the thing is, apolipoprotein B, there's only one of them on the lipoprotein. And you have to understand what this actually measures. So when lipids get synthesized by the liver, we've got the class very low density lipoprotein, VLDL. As that circulates and that donates its cargo, it actually shrinks a little bit. It becomes an intermediate density lipoprotein. Then it donates a bit more cargo and it becomes a low density lipoprotein. So we've got these three particles that we talk about in medicine as though they're three different entities, but they're really like a deflating balloon. They're exactly the same thing. It's just lost a bit of content, lost a little bit of air. And each of those three particles actually contains the ApoB100 moiety embedded within the membrane. So when we're measuring an absolute ApoB100, we're not always sure which one of these we're measuring. And it is significant because LDL is actually, we know the association of that with health is that it's actually probably better, higher. Whereas VLDL, which is really how we assess triglyceride level, that we don't actually directly measure triglycerides, we just calculate it based on VLDL level. VLDL production, which is driven by lipogenesis, we know is actually associated with poor health. So there are some limitations, and you have to understand the underlying biochemistry and the physiology of how these lipids are generated. In general, its ratios are better. So I certainly wouldn't look at ApoB100 in isolation. But I generally feel if you're looking at a HDL to an ApoB ratio, that would be better, or a triglyceride to HDL ratio. But understand that when you're looking at B100 levels full stop, you don't really know everything that's making it up. You can measure it, by the way. You can do something called a lipid electrophoresis, but that's over $100, and you probably want to know how to interpret that before you order it.
Great, thank you.
Sorry, I know that's possibly not an overly helpful answer, but there is a bit of nuance to that. Well, I think in the interest of time, we better move on. So thank you so much. Fabulous. And if we can take another volunteer and move on to case-based discussion number 2.
Hi, Paul. Laura here in Melbourne. I'm happy to jump in.
Oh, lovely. Thank you. Pleased to meet you, Laura.
Nice to meet you.
Now, so what we've got here, we've got a pretty common presentation. We've got a 32-year-old patient, and she's got gastrointestinal symptoms, and they appear to be postprandial. So what are your first thoughts? What jumps into your head about this to start with?
So my initial thoughts, or just from the alternating diarrhea and constipation, is a possible presentation of mixed IBS. Was my that was the first thing that stood out to me.
Absolutely. I mean, it's textbook. And almost certainly it is. And we'll get into that and management for that. But is there anything that, even though this is probably that, should we exclude anything?
Yeah, 100%. So 32, quite young still. So the key is you want to rule out IBD. So doing initial bloods, and in particular a fecal calprotectin is quite sensitive for IBD and inflammation in the gut. And also,
well, let's just say, first of all, textbook straight up. That's exactly how I would approach it. But let's dig down into these tests. I think we need to, when we're ordering tests, it's useful to understand what we're actually looking at. Fecal calprotectin, beautiful. So this is a measure of neutrophilic activity in the gut. Now, not all inflammatory bowel disease is neutrophilic. We've got, for example, eosinophilic esophagitis, we've got lymphocytic colitis, so on and so forth. So it is, while it is very good, and it is probably one of the most sensitive tests for inflammatory bowel disease, it's also useful to understand that there's potentially other types of inflammation within the gastrointestinal tract that fecal calprotectin won't pick up because it is a neutrophilic-based test. But anyway, sorry, carry on.
Oh, no, that's so I suppose to help with that, the level would be important. So greater than 150, I think it's nanograms from memory is the...
Yeah, well, let's assume that, okay, you're doing some excellent tests there. You're probably also doing a celiac serology. You're probably also doing nutrient levels because you want to make sure people with inflammatory bowel disease tend to have impaired absorption of nutrients. And we'll come back and talk about that in a moment. But clinically, in somebody's presentation, We know that inflammatory bowel disease is frequently associated with what we call the seronegative spondyloarthropathies, and you probably should all know the 4 subtypes of those at the moment, but there's so much overlap between them. I actually don't find the clinical distinction or distinguishing between those 4 groups particularly useful, but I know that people with joint pain, inflammatory joint pain, migratory joint pain, pain that's worse in the morning or after periods of immobility, frequently will have these inflammatory gut-related issues. So can you give me just clinically a few kind of things that you might look for on a physical examination or a history to screen for, inflammatory bowel or the associated seronegative spondyloarthropathy?
Yep. So inflammatory bowel on its own, the things I'd want to ask for is blood in the poo as well as mucus. I'd want to ask in terms of family history, as you said, ankylosing spondylitis, psoriatic arthritis, enteropathic or reactive arthritis. And you'd also want to know, is there a family history of HLA-B27 positivity, or have they had that in the past? In terms of musculoskeletal manifestations, you want to ask for, in particular, buttock pain or alternating buttock pain. You also want to ask about enthesial and the enthesopathies such as Achilles issues.
Yeah, let's talk that is a huge one. That is absolutely huge. So in my screen, I don't always ask because sometimes people just accept things as normal. You press on each of the bony prominences, the epicondyles around the elbow, the back of the calcaneus, and the plantar fascia insertion. By the way, plantar fasciopathy almost certainly is an autoimmune enthesopathy, which is probably why there's so many treatments being described for it that are largely completely ineffectual, and why when you inject them with steroid, they'll get a temporary, but they will get a definite relief for a period of time, because it's the immune system is doing a lot of the damage. So if we suppress the immune system with a corticosteroid, you will get some benefit. So, those kind of things. Do they get mouth ulcers? That's very common in Crohn's disease, and everything else. So, I mean, you're hitting this one out of the park. So, okay, so let's say that they do have, you've done some blood tests and the vitamin B12 comes back. And the vitamin B12, the reference interval is 135 to 650, because you've done a lot of them, you memorized it. And their level is 250. What do you think of that level of vitamin B12?
Obviously it's a very elevated value.
Okay, so the reference range is 135 to 650. So
to 650. Sorry,
they're about 200. So the point I'm making is the reference intervals don't reflect good health or optimal health, and we've got clear literature that anything less than 400 in serum B12 is suboptimal for health. And a lot of blood companies now, they'll have a little blurb, a paragraph below the vitamin B12 that says, if it's less than 400, you should consider it to be low or equivocal. Well, we know this. So don't always trust reference intervals when you're doing a blood test. That, if you've got a 95% confidence interval, you exclude the top 2.5%, the bottom 2.5%, and you're assuming that everybody else in the middle is optimally healthy, and that is simply not the case. We also see this with iron. I mean, as you guys see people all the time with a ferritin of maybe, 35 or 20. And sometimes now the lower end for females is set at 15, and they feel tired, they feel terrible, they're depressed because you may not know, but iron is a necessary cofactor for the synthesis of the catecholaminergic neurotransmitters like dopamine and serotonin. So we also know it's important for mitochondrial function. So we've got randomized controlled trials that show when you infuse females who are deficient in iron with iron, they actually lose weight because their mitochondrial function improves, their mood improves. So do not always trust the reference intervals when you're doing a blood test. I think that's a very critical point, and don't be afraid to do your own research. And by the way, if anybody ever wants to reach out to me and talk about this after the tutorial, because I know we're only touching on things, I'm really just trying to give you a taster give you visibility of what you need to learn about and where you need to direct your learning moving forward. I'm very happy to have conversations. All right, so let's assume that you've excluded inflammatory bowel disease. You clearly know your stuff. You're doing good blood tests. You do an excellent physical examination, and you diagnose irritable bowel syndrome. How do you manage this?
So one of the interesting things about in irritable bowel syndrome is that we actually still don't know the definitive cause for it. We have hypotheses about what the cause is, and so we direct management at possible.
Is there any evidence-based treatments? Is there, putting aside the limited understanding about the underlying pathophysiology, which I won't give you my idea on, but is there any proven treatments that have been shown on average to help patients?
Yeah, so gut hypnotherapy to reduce the neural sensitivity of the gut. So gut hypnotherapy and CBT. So there's the Nerva app, which can be quite helpful. There's also, you can do a low FODMAP diet in terms of restriction for 6 weeks and then a gradual introduction with trying to find what the main triggers are for patients, keeping in mind that evidence does show that the FODMAP foods themselves are not from memory, it's got to do with like the gaseous production from the FODMAP foods are the same in people with IBS and not IBS, but theoretically it improves symptoms because of, again, the neural sensitivity element of it.
Well, I guess not just theoretical. The patients tend to feel better. So, and given that you're very possible, I had questions on FODMAPs on my exam from memory. I have nothing to do with writing the exam, by the way. Given that this could be an examinable topic, it's probably useful for you to know a little bit about FODMAPs. Do you know what it stands for? You don't have to cite it all off, but what do the letters represent?
I think it's like oligo, mono, disaccharides, and
they represent
oil?
Things that are not digested very well. So it stands for fermentable oligo, monosaccharides, and polyols. But you don't have to know. I mean, actually, on one, I believe you might actually have to know what they stand for. But understand that these are things that are not digested very well. And if your body doesn't digest it or absorb it very well, your bacteria can have a field day. So what do the bacteria do? Your microbiome, what do they do if they come in contact with, say, a fructose that you haven't digested?
So I believe it produces, it ends up producing more gas as
exactly. It ferments it, and it produces gas. So if you've ever got anybody who's complaining of prominent bloating, well, that's really suggesting of microbial fermentation. Now, you can also have an osmotic effect, which is where you'll draw fluid into the feces. So that can explain why you'll get a bit of bloating. And you might also have loose stools. Now, depending on if you've got a methanogen-producing bacteria, we know that methane actually inhibits peristalsis. So you can have loose stools and constipation at the same time, which seems quite paradoxical. But when we actually look at the science and understand the role of the methanogen-producing bacteria, that's quite plausible. So understand that FODMAPs is a real thing, and a lot of people do significantly improve their symptoms when they do eliminate FODMAPs. And also understand that the P stands for polyols, which can be seen in artificial sweeteners. So people on low carbohydrate diets, if they're having, sugar-free chewing gum, you look on the back of those packets, they say warning excess consumption may have a laxative effect, and that's why a lot of people on low carbohydrate diets, they're trying to fix their their sugar problem, and they're having a lot of cauliflower mash. Well, there's a lot of indigestible foodstuffs in some of those foods that will lead to a lot of bloating. But look, we might move on in the interest of time, but essentially I'm very comfortable. I'm very happy with that answer. You seem to have a good grasp of what its different pathologies and solid investigation pathways. All right. May we please have another volunteer?
I'll volunteer Paul Martin in Canberra.
Brilliant. Thank you, Martin. So welcome today.
Thank you.
You've had a chance to read this STEM.
Yep.
What are your thoughts?
So we've got a competitive athlete in this STEM who's got a performance, a weight loss imperative from a sport classification effect and a time component to it. And so obviously you're balancing competing priorities of preparation and making weight. And you've got some information around his current diet, which has a high carbohydrate component. There's protein supplementation, and there's also potentially some extra nutrition that's not going to have a performance effect in terms of his occasional fast food. So he's got to lose 4 kilos to get down to 70. So that's, around 5% of his body weight. I think the main thing would be getting a clearer picture on the specifics of his diet, probably looking at the high carbohydrate content in the first instance, largely because of...
First question here, Matt.
Yep.
Is it realistic? Can he realistically lose 4 kilograms in 2 weeks?
Yes, you can. You can lose weight very rapidly. The questions that you would have around that is how quickly after weigh-in or making weight does he need to compete, and is there a period of time when he can put his weight back on?
So, I mean, this is clearly suboptimal. So but this is a realistic presentation. Athletes often find themselves in this situation where realistically they need to lose what is an excessive amount of weight. And there's no way that you can lose that amount of weight in terms of tissue. So you're going to have problems with, necessarily these athletes are going to dehydrate themselves. There's two ways about it.
Yeah. So you need to look at the implications of the carbohydrate component would largely be around glycogen storage because of the attendant water component of that. So if he's able to carbohydrate deplete, he won't be holding quite as much water from a muscle point of view. And then your issue around that is obviously reloading him so that he's got available substrate for wrestling, which is a fairly short-term power-based activity.
Let's get down to brass tacks here.
Yep.
So have you ever heard of a protein-sparing fast?
In vague terms, I've heard of it.
Basically a name for when we say, well, what happens if you consume almost only protein and you'll relatively deplete yourself of carbohydrate and fat? Now, the theory behind this, and I don't know that there's a lot of published research in making weight, is that you can attenuate losses of muscle protein while trying to lose other body compartments. Now, I guess the question is there any particular amino acids that are particularly important in protein to stimulate muscle anabolism that you're aware of?
So I don't know about the veracity of the science around it, but people looking around a bit like branched chains amino acids.
Well, branched chain amino acids so there's 3 of them, and one of them is leucine. And leucine is very important. Have you ever heard of the mTOR pathway?
Yes.
So leucine is a direct stimulant of the mTOR pathway. So if we're trying to maintain muscle while, potentially being in a catabolic state, a net calorie deficit, then maintaining adequate protein for an athlete, especially leucine-rich protein, is very important. Now, you saw earlier we presented the data on soy protein versus skim milk protein, and you saw that the fractional protein synthesis rate was 43% higher in the skim milk. So the source of protein is very important. So we know whey protein isolate. There's a beautiful study done quite some time ago now that showed that, about 20 grams of whey protein was pretty well optimal for stimulating, maxing out your mTOR stimulation, and dosing it about 4 times a day. And you can get equivalent protein from beef powder or what have you. But the whey was shown to be superior to the casein. And dosing that about 4 times a day kept things around the clock, near optimal. So if you've got an athlete who you're going to have a caloric deficit, but you don't want them to lose muscle, and you obviously want to stimulate the mTOR pathway, then that kind of protein intake is probably important. We won't talk too much about hydration, but just as you've correctly alluded to, how much time do you have to recover afterwards? It's not realistic to lose 4 kilograms in 2 weeks without dehydrating yourself. You need to make sure that you're going to have some good rehydration strategies, and understand that necessarily means that you're going to have consideration to what electrolytes are coming back in. the other concept is we talked about micronutrients before, including phosphate and sodium and so on and so forth. So if somebody is going to be in that state and you don't want them to lose too much muscle, you need to make sure that their micronutrients are coming in adequate amounts, and that might need to be supplemental. And that obviously poses some issues with regards to WADA legislation, because a lot of these things are not batch tested. Some of them will fall under the guise of being a sport food supplement, in which case it's reasonable, and some of them won't, and that's going to be for some difficult conversations. Do you have any other thoughts or anything you'd like to talk about specifically on this?
No, so I think the main practicalities we've touched on with that, because it's a balance between performance and then what they're doing currently, and what you can marry between taking energy fueling away from a need to continue doing any training during that 2-week program, etc., and then having discussions around, what's their actual performance capacity going to be if they're going to be operating in such a deficit state.
Yeah. And I think just to finish, there's one more point about keto adaptation. So this is not a time to say we're going to put you into ketosis and we're going to aim to, make you a keto adapted athlete. If you do that, this person will perform below their peak. The process of keto adaptation, from that recent study we saw, it took 4 weeks to get back to baseline glucose levels, which was a significant determinant of exercise performance. And there's other data that shows that potentially it could be, for elite level performance, it could be 3 months or more before you get towards your peak performance. And I'm aware of some world-class athletes in triathlon who have been demonstrating performance benefits up to 18 months after going to a ketogenic diet. So this is not a discussion about, we're going to make you ketogenic because that's going to, lose the weight the quickest and have you performing the best. The period of keto adaptation is simply too short, and it would be inappropriate. You're just setting this athlete up for failure if you go down that pathway at this stage.
Yeah.
All right. Well, thank you, Matt. Excellent.
Thanks.
May we please have the second last volunteer? Please ignore the iron deficiency. When I was first writing the STEM, I was going to make it an iron deficiency case, and I decided not to.
I'm happy to chat to this one, Paul.
Fabulous. And your name?
Ione, I'm in WA.
Fabulous. Well, thank you so much. So we've got a 19-year-old cross-country runner here, and she hasn't had a period for 6 months. She trains quite a lot. She runs quite a lot. She's lean, but not excessively. Certainly, she's not as lean as many competitive runners, but she has lost a bit of weight. And her DEXA scan shows that technically she's in the normal range. What are your thoughts?
So a couple things. I'm wondering what her Z score is, just based on the fact that she's 19 years old and we want to compare this to someone of her age. Weight and ethnicity, and the T score isn't really representative.
Well, just on that point, that's a really good point you raise there. So T scores against a 30-year-old match control, whereas Z score is age match control. But you said you want to compare her to somebody more similar to her peers. So what other factor would we like to compare her against? And we may not have data for this, but what should we be considering? That's a really cumbersome question. What I'm getting at is this girl is an impact athlete. She's a runner. What would you expect the bone mineral density of a runner to be compared to the normal population?
I guess it depends on what sort of weight-bearing sport they're doing. So long-distance running isn't as good bone stimulus as change of direction sport or lifting.
That is true.
Sports would absolutely expect it to be above the normal range.
Correct. So, and this is really important in the context of athletes. And if you're getting any questions on athletes, and you sort of, I think it's important to provide that nuance that in a weight-bearing athlete, I would expect the bone mineral density to be superior to the general population. So even though this might not cross the diagnostic thresholds for being pathological, I'm going to consider this a problem. So that, a great start. All right, carry on.
what else would you like to know?
Well, okay, well, let's have a look at it. So, what do you think might be going on? Why is she not having a period?
It sounds like she's got, well, it's a diagnosis of elimination, but essentially sounds like functional hypothalamic due to relative energy deficiency syndrome.
Perfect.
Depends on the blood tests, but excluding causes. Looking like we need to know what her testosterone is to see if she's got.
So everything you've said is spot on so far. So we need to exclude a whole lot of other causes. Now, for the purposes of, medico-legal safety as well as exam passing, what's the first thing you should always do?
Is she pregnant?
Pregnancy test, straight up. Now, in terms of functional hypothalamic amenorrhea, we exclude other things. So we have polycystic ovarian syndrome to exclude. So what test would you like to do to exclude PCOS?
So it'd be obviously history, so signs of hyperandrogenism, but really I would like to just do bloods to start with, plus minus. Well, I'd normally do a pelvic ultrasound as well. So you do bloods with your testosterone and sex hormone binding globulin. And then you also want to see what her FSH, LH.
Okay, so you alluded to basically the Rotterdam criteria. So pelvic ultrasound will look at the ovaries, see if they're cystic. Fabulous.
Yeah.
So, you should know what the Rotterdam criteria are, even though that, that's an imperfect criterion. Have a look at the testosterone levels. So, yes, you are correct. We look at the sex hormone binding globulin. That will then give us visibility of the free testosterone as well as the total serum testosterone. But it can be difficult to interpret. I find this sex hormone binding globulin can often be inexplicably elevated. And when I've looked into the literature, I myself haven't been able to understand fully the drivers of sex hormone binding globulin. So I tend to not put too much influence on that just personally because I personally don't understand why it goes up and down. We obviously have a look at luteinizing hormone. Luteinizing hormone is a strong driver. So while we're talking about luteinizing hormone, and it usually pairs with follicle stimulating hormone, if it were functional hypothalamic amenorrhea, what changes in luteinizing hormone and FSH would we expect to see?
Essentially, like it's anovulatory, so you wouldn't see spikes. You just see sort of low levels.
So if we think about the pathology of it, so let's have a think about if this was another pathology, primary ovarian failure, and the ovaries just stopped working, we would expect the anterior pituitary gland to be pumping out copious amounts of FSH and LH to try and get the ovaries to work. So primary ovarian failure, we'll see, okay, how do we know the ovaries aren't working? Well, you're going to have low estrogen, and we would expect to see very high levels of FSH and LH. But functional hypothalamic amenorrhea is the problem is from the pituitary gland. The body says, oh, I don't want this to work. So you end up, the FSH and LH end up being typically low or perhaps normal, but you're still with a low estradiol. The normal appropriate response to low estradiol should be the body saying, well, we want more estrogen, we're going to stimulate this, so your FSH and LH should go high. But if you're in an energy deficiency, you won't be able to, that won't happen. So you'll end up with an inappropriately low or normal FSH or LH. So that, and obviously, as you've said, you rule everything else out. So hyperprolactinemia, test the thyroid, and you've already mentioned the androgens for PCOS, so on and so forth. One other thing which we won't go too much on just in the interest of time is that you can also have amenorrhea with malabsorption conditions, which we touched on earlier, things like celiac disease. You might want to check their teeth for dental enamel hypoplasia, so on and so forth. And when we're diagnosing celiac disease, again, it comes down to the reference intervals. If you're doing celiac antibodies in the blood and you see, somebody's got reasonable levels of celiac antibodies, they're definitely detectable, but they don't cross the diagnostic threshold by which we consider them to be pathological. You've already proven the fact that they've got those antibodies there. You've already proven an immune reaction to the consumption of gluten. Now, whether or not that passes the threshold for which you go and do a biopsy and prove celiac disease, if you're proven a reaction to gluten, then in my book, that is enough to warrant a dietary advice to restrict gluten. Another thing to bear in mind, and we see this frequently, and gastroenterologists know this, is that in about 50% or more of patients with celiac sensitivity, they also have cross-reactivity to casein, which is about 80% of the protein content of dairy. So if you've got somebody with a proven reaction to gluten and they're not responding optimally on a gluten-free diet, the next step should be to recommend they cut out the dairy and see if you're getting any benefits with that. Now, in terms of, okay, that you've diagnosed functional hypothalamic amenorrhea, and we know low energy availability is a significant contributor to that. Can you just talk to me about what you understand about what hormones might impact on energy availability? Hormones like insulin.
Sorry, I'm not answer with
It was a very poorly worded question. So remember I showed you that that graph that Kara Ebling and David Ludwig study earlier, and they showed that subjects on low carbohydrate diets were actually burning 300 kilocalories more per day at rest. Simply because they went on a diet that lowered their insulin levels, they were burning more energy. That to me implies that their energy availability has increased. So we tend to normally historically assess energy availability in terms of caloric intake. Now, do you think that's a reasonable assessment of energy availability, or do you think that's deficient in terms of it doesn't take into account the hormonal responses to different macronutrients?
Yeah, I would agree with that.
So
it's also, I mean, also her load as well. Like you're talking about intake, but also it's expenditure.
Exactly. But so one thing is we tend to these type of patients tend to be on very high carbohydrate diets. They're very low in fat because they've been told that fat is bad, so they want to maintain a low weight. So they're basically on an insulin stimulating diet. And we know that insulin, the job of insulin is to take energy and force it into fat stores. I didn't go through the biochemistry of that today, but the molecular mechanisms are well documented. Insulin takes energy and pushes it into fat. So energy availability, and this is something that is not talked about enough, even on the review papers on the red S, which is also typified by low energy availability. The hormonal influence of foods needs to be considered when we're looking at potential causes of low energy availability. We also, this lady, has got suboptimal bone health. What nutritional strategies would be important in optimizing her bone health?
So I think you would obviously ensure that she will, with her bloods, you check her vitamin D levels, and you're obviously going to check her parathyroid hormone, calcium, just to make sure there's no other causes for her, lower bone density. And then I guess pending the outcome of that, you could look at supplementation, but also just make sure she's achieving adequate intake of calcium in her diet as well.
Is there any other micronutrients in addition to calcium, or even macronutrients that might be important for bone?
Protein and is going to be important.
Well, not so much fat, but protein. So remember, the dry weight of bone is 30-40% protein. So high protein intake is absolutely essential. And we also know that hydroxyapatite is a strong phosphate content. Phosphate's very important. We know that bone also contains sodium and a bit of potassium. So basically all of these micronutrients, and exactly as you said before, vitamin D. Now, vitamin D isn't so much found in bone itself, but it does enhance the absorption of electrolytes. And it's not just calcium that it enhances the absorption of. So whenever I'm giving people nutritional recommendations on electrolyte mixes and protein intake and so on and so forth for their bone health, I always make sure that I include advice on vitamin D, as you suggested, because that enhances that electrolyte absorption. All right. Well, we probably best move on. Thank you so much for that. And we'll ask for one more volunteer for our final case.
Hey, it's Steve here from Adelaide. I don't mind
Welcome.
taking this one on. Just based on the talk that in the pre-reading you mentioned about Ozempic and what the studies have shown in terms of body composition that's actually lost instead of total percentage of body weight. And your mention was with regards to lean mass, so bone and protein loss, and even with stopping semaglutide or any of the other comparators on the market, that when they regained weight, a lot of it was the fat regaining instead of the lean mass regaining. So the concern, obviously, with the persistent medial low tibial pain is, whether they've lost significant bone mass and potentially have a stress fracture.
Exactly. So, I mean, I think you've hit all the key points there straight up. So thank you for that, Steve. So first of all, tibial stress syndrome. My previous training, we were taught that it was Sharpie's fibers and so on and so forth, and attraction apophysitis. And the evidence is very clear now that it's actually bone stress, straight up bone stress. It's a load management problem. And obviously you need to consider the medial border versus the anterior border, whether you've got compressive stresses and tensile stresses and all that. But that's, for the other tutorials that you'll cover that in. But basically, tibial stress syndrome, I wrote this as a bone stress issue, and you've identified that correctly. So let's have a wee look. I actually set this up. I've got a few slides. You've seen that already, but if anybody hasn't watched it, we'll just go through some of those slides now. So, Ozempic is very popular. We're seeing more and more athletes using it, and this is really problematic because it actually does impact. It will impact on their health and on their performance. So one of the trials, a drug company funded trial for Ozempic, was called the Step 1 trial. Now, this demonstrated that over 68 weeks of the more than 1,300 participants, they lost an average of 16.86 kilograms, which is quite huge. And, even athletes struggling to make weight, they're drawn to this drug. But when we look at the DEXA body composition scanning data, and that was available for 95 of these 1,300 subjects, we can actually see that 39% of the total weight lost actually came from lean tissue. Now, interestingly, this data was not in the main publication. You had to go to the supplementary data to see this, and there wasn't mention of this in the main article, which is why you need to keep digging. So don't just accept things as they're presented straight up. So we know that bone and muscle are important for athletic performance. Indeed, they're important for health, full stop. Now, we know that this also increases the risk of fracture. So there's another drug company funded trial. And I say drug company funded because you know that if there's going to be bias, it's going to be in the favor of the drug itself. This is called the SELECT study. And this actually, and the information from this study wasn't available through the study itself, but rather through the TGA website. So when drugs get approved, companies actually have to submit a lot of trial data and even unpublished data. And presumably this was made available to the Therapeutic Goods Administration. And this information from their website indicates that the risk of hip fracture for females taking Ozempic in this trial was increased by 5 times, which is bloody huge. And this is a real-world complication. And athletes at risk of stress fractures, this is going to cause a lot of complication. If you've got an athlete you're managing for bone stress, they should not be taking Ozempic. This was a double-blind randomized controlled trial conducted at 2 public hospitals in Denmark, and that looked at weekly Ozempic injections over 52 weeks, and it found that it resulted in bone loss mass in the spine and the hips and thinning of the cortical bone of the tibia, which is why I based this question stem on it. But more concerningly, so they followed it up for 52 weeks, and they measured bone breakdown markers. Here you can see C-terminal telopeptide levels, and you can see that those levels are continuing to rise in the blue line in the active group. They're getting higher the longer the study goes on. Now, my feeling is that's a definite trend, and that's not showing any signs of stopping. And so the longer people are on this drug, it's likely that their bone breakdown will continue to accelerate. And again, this is a problem because these drugs have been approved for basically indefinite use. And even if they're not being used for an approved indication, we know that people are taking them off label, very common. And when you understand that if you stop taking these drugs, then you get the weight back. So these athletes who are trying to make weight, they're faced with a real conundrum. Do they stop taking the Ozempic and regain the weight that they've lost? Presumably mostly muscle. We've got no evidence that they'll regain bone or muscle because we haven't been presented with the DEXA body composition data from that. So we probably should assume that it's going to be the fat that they're going to be regaining. Otherwise, I'm sure they would have told us. So they either regain their fat that they've lost or their bones continue to deteriorate. So it's really a catch-22 problem with that. So I guess at the end of the day, be very careful of your patients taking Ozempic. And if they insist on taking Ozempic, then remember what we said about leucine-rich protein. So you want to stimulate the mTOR pathway. You want to make sure they're provided with all the micronutrients of bone. You want to do absolutely everything in your power that you can do to minimize, attenuate the degree of bone mineral loss that they're going to suffer. And almost certainly they will suffer it. All right, I think that is, I've just gone over, we're 5 minutes over. So we better leave it there. But thank you so much for everybody coming along. And I don't know if it's okay. I'm happy to take questions unless there's strict rules about the tutorials winding up on time.
No, good. If anyone's got any questions for Paul, feel free. I think we'll take that as a no, so we'll wrap up there then. Thanks, Paul. Thanks for your time today, and thanks everyone for joining. We'll see you next week, and best of luck to those that sit in the clinical exam tomorrow.
All right. Well, I didn't know there was a clinical exam, but good luck for everybody sitting that, and thank you for putting up with my hoarse voice.
Thank you.
Thank you. Thanks very much.
Thank you, Paul.
Thank you.